Welcome to The Explainer. All right, today we're tackling a big one, a diagnosis that's super important for your rotations and your boards, small intestinal bacterial overgrowth, or SIBO. It's one of those conditions that can look like a dozen other GI problems, so really nailing the key features, absolutely crucial.
Okay, so let's just jump right in with a classic case. Picture this. A patient comes to your clinic. They've been dealing with bloating, diarrhea, and they've lost some weight without trying. You're working them up, you send off some labs, and then you see it, the real head scratcher. Their folate level is high, but their vitamin B12 is in the basement. So what diagnosis should be shooting to the very top of your list?
If you were thinking SIBO, you are 100% correct. So what exactly is SIBO? Well, when you boil it all down, it's really just a problem of having too many bacteria in the wrong part of the gut. It's like a party happening in a room that's supposed to be a quiet library. So let's get into the why behind it. So here's the main idea. SIBO happens when bacteria that should be hanging out in the colon decide to move upstream and set up a huge colony in the small intestine. Normally, your small bowel's kept pretty clean, right? But when these guys take over, they start messing with your digestion, they start interfering with nutrient absorption, and that's what leads to all those classic symptoms of malabsorption. Okay, so the big question is, how does this even happen? I mean, the small intestine has this amazing security system in place to keep the bacterial numbers low. SIBO only happens when those defenses break down. So let's take a look at what can cause that security system to fail. It really boils down to four main categories of risk. First, you've got structural problems, things that create little nooks and crannies where bacteria can hide and multiply. Second, motility issues. The gut's cleanup crew just isn't moving things along fast enough. Third, not enough stomach acid, which is usually the first line of defense. And fourth, other systemic diseases that just throw the whole gut environment out of whack. And when you look at the specific causes, the list is pretty long and diverse. You've got things like surgical blind loops or strictures from Crohn's that create stagnant flow. You have slow motility from things like diabetes or even chronic opiate use. And yeah, even long-term use of acid-suppressing meds like PPIs, though there's some debate there, can lower that acid shield. This is a huge differential you got to keep in the back of your mind. All right, let's circle back to our patient from the beginning. We're thinking SIBO. The symptoms fit, and those labs are just screaming the diagnosis. But a suspicion isn't enough, right? So how do we actually prove it and lock in the diagnosis? And this slide, this is such a beautiful high-yield concept. It perfectly explains that weird lab finding. So why the high folate and low B12? Well, it's all about what these extra bacteria are doing. They are like little folate-making machines, churning it out right there in the small bowel where we can easily absorb it. But they're also greedy. They gobble up all the vitamin B12 for themselves before our body gets a chance to absorb it. Seriously, lock this pattern in your brain for your exams. Now, if you want the absolute, undisputed best way to diagnose SIBO, that's going to be a jejunal aspirate. And that means exactly what it sounds like. You go in with a scope, you get a fluid sample directly from the small intestine, and you send it off to be cultured. And the magic number you're looking for on that culture report is this, greater than or equal to 10 to the third. That's 1,000 colony-forming units per milliliter. If you hit that number, you've got your diagnosis. It's definitive. But let's get real. The gold standard is great in theory, but it's invasive, it's expensive, and it's just not done very often. That's why in the real world, we almost always turn to the more practical workhorse, the hydrogen breath test.
So how the heck does a breath test work? It's actually pretty genius. You have the patient drink a specific sugar solution. Now, if there's a bunch of bacteria camping out in the small intestine, they're going to ferment that sugar and produce gas, specifically hydrogen. We then measure that hydrogen in the patient's breath over a couple of hours. A big early spike in hydrogen tells us the party is happening in the small bowel exactly where it shouldn't be. And here are the numbers you got to know for a positive test. If you're using lactulose, you're looking for a rise of more than 20 parts per million inside of 2 hours. If you're using glucose, it's a rise of more than 12 parts per million in 3 hours. That early peak is everything. It's what tells you this isn't just normal fermentation happening way down in the colon. But, and this is a big but, the test isn't foolproof. You have to know its pitfalls. For instance, if a patient's gut is moving at lightning speed, that sugar can get to the colon too fast, giving you an early peak that looks like SIBO, a false positive. On the flip side, especially with glucose, the sugar might get absorbed too high up and never even reach the bacteria, giving you a false negative. It's all about interpreting the test in the context of your patient. So let's say we have our diagnosis confirmed. Now what? Let's move on to the game plan. How do we treat this, and what do we need to watch out for? The cornerstone of treatment is pretty straightforward: antibiotics. The goal is to basically debulk that overgrowth. And the star player here, the one you'll hear about most, is rifaximin. The reason it's so great is that our bodies barely absorb it, so it stays in the gut to do its job with minimal side effects. The only catch? It can be pretty expensive. Of course, there are other good options like doxycycline and metronidazole.
Now, I know what you might be thinking. Why not just fight bad bacteria with good bacteria? What about probiotics? And it seems like it would make sense, but, and this is a really important point, probiotics are not recommended for treating active SIBO. It's kind of like trying to put out a fire by adding more fuel. The evidence just isn't there, and the official guidelines are super clear on this. It's a no-go for treatment.
All right, now for the tough part about SIBO. It loves to come back. I mean, recurrence is incredibly common. Think about it. You can clear out the bacteria with a course of antibiotics, but if that underlying problem, that structural issue or slow motility is still there, the bacteria are just going to grow back. This means managing SIBO is often a long-term strategy, sometimes even requiring cycles of antibiotics to keep symptoms under control.
Okay, let's bring it all home. We've covered a lot of ground. So if you're going to remember just a few things from this explainer for your exams and for the clinic, let it be these key points.
First, that gold standard diagnostic number. For a jejunal aspirate, it's 10 to the third, or 1,000 CFUs per ml. That's your definitive line in the sand.
Second, that classic board-style lab pattern. Say it with me. High folate, low B12. The bacteria make one and eat the other. Don't forget it.
Third, when you think treatment, think rifaximin. It's your safe, minimally absorbed antibiotic of choice. Yeah, it's pricey, but it's the go-to for a reason. And finally, and this is probably the single most important point for long-term success, you have to treat the underlying cause. SIBO is almost always the consequence of something else. If you don't address that root problem, you'll just be spinning your wheels.
And that's what I really want to leave you with. We know recurrence is a huge problem, and we can't just keep throwing antibiotics at patients forever. So it really makes you think, what's next? What role will things like motility agents, drugs that actually speed up the gut, or very specific dietary changes play down the road? How do we finally get ahead of this thing and move from just treating SIBO to actually preventing it from coming back? That's the real challenge for us going forward.